So now I invite Dr. Kimaya Chavan to speak on AC maintenance, the third surgical hand.
Dr. Kimaya is also a trainer with Help Me See, and Help Me See has been a partner of ISMS-ICS for last 10 years, and they do yeoman work in training youngsters and the not so young in various types of cataract surgeries, earlier only manual SICS, but now also phaco. So over to you, Dr. Kimaya.
Okay. At the outset, I'd like to thank ISMS-ICS and the organizers of AIOC for giving me this opportunity. Let's start. Yeah. So we know we have different techniques of, can you hear me now? Yeah. We have different techniques of dealing with the nucleus in M6 procedures. So let's talk about ACM today. So this basically, antechamber maintainer has a serrated margin and he has a bevel edge. And the cannula is a single port cannula, which is very slender. This comes in different sizes and different patterns are also available of AC maintainer. So first we'll see how to insert the AC maintainer. You have to go with the MVR blade inside and go towards 6 o'clock, pointing towards 6 o'clock. And you have to insert the antechamber maintainer then, and first the bevel should be always up, and then you have to make the bevel down. Okay, that is very important. Then second thing is, it shouldn't be very long or short. If it is too short, it can come out easily. If it's too long, it can come in the way of instrumentation. Always check the patency of it, remove any air bubble if it is there, and then start. And the bottle height should be around 50 to 70 centimeters ahead. So we'll see now the role of AC maintainer in all these different steps of cataract surgery, how it helpful. So this, in tunnel construction, you always know that whenever you have to have a tunnel, you have to have positive pressure from within the globe. Like, you know, if it is very soft, it's difficult for us to make the tunnel, right? So you have to have a very good positive pressure. So AC maintainer does the same thing. It gives you adequate counter pressure, so tunnel becomes very easy for the surgeon to make out. Also, the keratometry becomes very easy when you have AC maintainer inside. In Rex's creation, you have actually, it's very quick and easy. Only when the surgeon is novice surgeon, sometimes you have difficulty when there is a flap, it flutters. But that time you can actually hold the flap with the other hand, instrumentation from paracentesis, and make it flat on the lens. So that becomes easier then. And of course, it's not a crime to use viscoelastic, right? When you have ACM, it's okay. To start with, you can use viscoelastic as well. In nucleus delivery, Dr. Neeta actually explained beautifully how to use this sheets glide. And as she said that, yeah, you can use this also, the iris depositor. At the same time, you can use McPherson forceps also to take out the nucleus. In cortex wash, it is very easy because you have a very slender cannula. You can have very good aspiration at vertical cortex also. And because the AC is well formed here, because always the ACM is there, and the PC is quite low, so chances of PC rupture are very less. So it's very good for to start with as a novice surgeon. Always the pupil is dilated, and there is less chance of expulsive hemorrhage because there is always positive pressure. So that is also a very important point. In IOL insertion, yeah, to start with, you can have some problems because when you insert the IOL, because the pressure of the ACM, or the water hydrostatic pressure, the lens can start coming out, but you can do it with practice. And you can, as I said, you can use viscoelastic for first few cases, and then you can shift to only ACM. It's a learning curve, but you can definitely do it. Yeah, in the case of posterior capsular tear also, because it is positive pressure, there is less disturbance of hyaloid phase. So it prevents the further vitreous loss, and it maintains the AC, reduces fluctuations, and you can directly actually put the IOL inside the sulcus. Whenever there is vitreous loss also, you can go ahead with vitrectomy without any complication further, and you can easily aspirate the cortex with the ACM there. So advantage of ACM is there's a one-way flow, there's a low turbulence, then no post-op IOP spikes, less chance of inflammation of postoperative because we are not using viscoelastic, less chance of TAS, less endotoxin contamination. As is continuous irrigation of medication, you can even go with give adrenaline or antibiotics to the AC maintainer, and it also acts as tamponade to prevent the bleeding. In different scenarios, you can use AC maintainers, like if you have to just implant secondary IOLs, descended IOL dialing, of course, washing any cortical matter which is remaining in previous surgery, removing intra-foreign bodies. Even sometimes people are doing trap under ACM as well. Injecting air or visco are some variations you can do with ACMs. And basically, retinal surgeons, they do procedures on vitrectomy's eyes with ACM maintainer. And there is something called as trocar ACM, which is pioneered by Dr. Amar Agarwal. So it's something like this. The trocar looks like this, everyone knows. So what you do is you go transconjunctival, 0.5 millimeters from the limbus, 45 degrees first, and then you enter perpendicular in the anterior chamber. Okay? And then you can remove the trocar and attach the infusion line. And then you can use it same like AC maintainer. It is very useful in retinal surgeries as well. And these are all different techniques of SICS, but whatever the studies are saying that post-op surgical astigmatism was comparable in all the processes. Not very different in AC maintenance, they are all comparable. And as even of us know that ECC, SIS and FECO, least endothelial count losses in M6 surgeries, SIS surgeries. So as all these are very prominent figures in M6 procedures, every M6 procedure it has own beauty of its own and its perfection. Okay? Thank you so much, and my sincere gratitude for Dr. Boramani and Eli Prasad for the videos. Thank you so much.